Welcome to Procure Health Talks, a webinar specially designed for men affected by prostate cancer and their loved ones. The various topics covered in these webinars are intended to provide reliable information based on the concerns and questions asked to Procure healthcare professionals. Let's begin.
Hi everyone, welcome to Procure en Parle. My name is Kim Sullivan. Today we're going to speak about urinary incontinence. Many believe that this only affects women, especially those that just gave birth, for instance, and women must do exercises in order to avoid urine leakage. But many don't believe in urinary incontinence in men. We don't hear about it so much. However, men are confronted with urinary incontinence. So what about urinary incontinence that is not related to prostate cancer treatment? That's what we're talking about tonight with Dr. Vincent Trudeau. He's a urologist and surgeon at the university-affiliated hospital in Trois-Rivières. Thank you, Dr. Trudeau, for being with us. Good evening. Since this is the beginning of the webinar, I'd like to start with some more generic questions. So first of all, what is urinary incontinence? Sure, this is fairly simple. Urinary incontinence is when patients complain of involuntarily losing urine, so it needs to be involuntary. To give you an idea about percentages, among women, there was a survey a few years ago. We're at about 25 to 30% of women complaining about urinary incontinence. In men, the figures are between 5 to 7%. This comes along with some diseases, but this is also perhaps due to men not disclosing their incontinence so much to their physicians, so that's why we're lifting the veil tonight. So we know that with women, it happens postpartum. With men, are there several types of incontinence? And if so, what are the related symptoms? Well, for both men and women, there is incontinence, but we're focusing on men. There are three types of urinary incontinence. We talk about stress incontinence. So this is due to exertion. So when you're coughing or laughing or doing a physical activity. The next type is urge incontinence. This is an urging need to urinate and the patient cannot make it to the restroom on time. There's also mixed incontinence, so a mix of the two previous types. There are other unofficial types of incontinence. I will mention two. One is overflow incontinence. So this is related to urinary retention, so the bladder is full. Men will have some dribbling happen. This is not a stress incontinence. This is really with the bladder that's full and there's a blockage. The last one that is not incontinence but that should be mentioned is post-urination dribbling. Men will be done passing urine and then some drops will keep dribbling. So this is an incontinence. It's just a little bit of urine that's stuck in the canal. We just need to relax and let it flow out. There are techniques to do that, but that is not considered incontinence. So this isn't always a sign of any issues related to the prostate, right? There can be other reasons that explain this incontinence. Correct. So men, when they have urinary issues, tend to think, oh, I have a prostate issue, but it could be due to the bladder or the prostate. So for instance, stress incontinence is often related to prostate surgery cases. Urge incontinence could be related to an overactive bladder, which can be related to the prostate issues. It could be radiotherapy related. Overflow incontinence could be due to a blockage to various things. And a whole other component that is much more rare is neurological diseases that can have physical symptoms. So definitely not just correlating urinary symptoms with prostate issues. Right, it's one link that people tend to think of. How can we know whether my urinary incontinence or that of my spouse, say, How can we know if these urinary symptoms are indeed related to an enlarged prostate or an infection or even prostate cancer? Well, what we need to understand is that prostate cancer rarely leads to symptoms. Most cases are asymptomatic, so patients feel no symptoms unless there's specificities involved. An enlarged prostate, along with aging, what we call benign prostatic hyperplasia, leads to obstruction. So the patient has trouble urinating, the outflow pressure is reduced. The prostate, when it is enlarged, means that the bladder has trouble emptying out and can become overactive by fighting against this obstruction. So sometimes patients can have urge incontinence with the bladder contracting often for no reason. But this is secondary to prostate issues in that case. With urinary infections, this is different. There will be pain, a sensation of burning, and other symptoms. So with a few questions, we can spot the differences. These symptoms need to be taken seriously. Patients tend to think, oh, it is going to be prostate cancer as soon as one symptom shows up. That is not the case. It doesn't mean we shouldn't screen for prostate cancer. It simply means that this is not the only reason. You mentioned that aging leads to muscles relaxing somewhat. Is it fair to say that all men will experience incontinence at one point or another due to aging? Well, so we know that the prostate enlarges with age. However, the idea is not the larger the prostate, the more symptoms. No. Some patients have a small prostate and have a lot of symptoms. And some patients have a very much enlarged prostate and have no symptoms. But yes, statistically speaking, the larger the prostate, the more likely you'll have symptoms. But not all men will experience any prostate issues. And just as far as context, the muscles don't quite relax. It's the bladder that will try to contract because of an enlarged prostate. So the outflow pressure will be reduced, and that can also lead to, again, urge incontinence because the bladder is contracting or because it is not emptying out and we're just getting rid of the overflow every time. You're gesturing here this pressing motion on a jet spray or pressing on a straw, say. So this is a similar concept, right? Precisely, yes. This is just like an engine and its components. So the bladder is contracting. It can have trouble contracting for any reason, but the bladder contracts, and then the plumbing can be open or closed, and then there's a whole dynamic in between the two. So if the plumbing is partially blocked due to an enlarged prostate that's obstructing, then the bladder may have trouble emptying out or will contract more often. So we need to see this as a whole. It's plumbing. Yes. Yes, I think the image is very helpful. It's nice to see this image because I'm sure a lot of people just went, now it makes sense. Should we be concerned about the presence of blood in urine? Is this part of urinary incontinence symptoms? Should we see a doctor immediately if we spot any blood in our urine? Well, so as soon as we see blood in urine, automatically you need to see a doctor. Sometimes people say, oh, maybe it's just a stone that's passing, but that's not necessarily the case. Blood in the urine doesn't mean any emergency, but any man or any woman seeing blood in urine need to see a doctor. There's a whole array of tests in urology, and also family physicians can get some tests started by asking for images for looking at the kidney and other plumbing components. We'll also look at the bladder to make sure that this part is doing okay and that this isn't where the bleeding comes from. So it's rarely associated to incontinence, but this is a red flag. We need to see a doctor if that happens. We often say that in women from 45 years of age, we should have mammograms. Is there a specific age among men from which incontinence can be expected to appear? And can it lead to other physical symptoms? Well, so with age, men can develop urinary symptoms, but incontinence, if it's a new onset, newly developed, we need to ask why this happens. In women, statistically speaking, it's frequently due to pelvic floor muscles being weak. In this case, we need to strengthen them through exercises, and there's a host of reasons, including an overactive bladder. Among men, there could be an overactive bladder, but we need to eliminate other causes, such as the bladder not fully emptying out. So, with a new incontinence onset, we need to figure out what's underlying. It doesn't mean necessarily that we need to see a doctor urgently, but it's something to look into, especially if incontinence occurs before urinating, as opposed to post-urination dribbling, a few drops as you put your pants back on. That's not serious. But de novo incontinence, then we should look into this. So there is no specific age where we can think, no, so it's not from 70 years of age, it's normal to have urinary leakage. It doesn't mean that it's serious if you do. It just means that we need to ask the question and discuss this with your physician so that we look into the cause. Could this be linked to erectile dysfunction? So normally there is no correlation between urine leakage and erectile dysfunction. However, patients may have erectile dysfunction due to the psychological impact of urine leakage during sex or being scared to lose urine because they did during masturbation. So there is a psychological impact component there. In some very rare cases, it could be linked to neurological disease affecting both. But, erectile dysfunction is quite common, and urinary incontinence is also common, so one could have both issues simultaneously without them being linked in any way. In a minority of cases only, this would be the case. And sometimes we say, that men delay seeing their doctor, so especially in this case, it's quite possible that both symptoms are concurrent without them being linked or one causing the other at all. Indeed, it's very rarely the case. They're typically two distinct reasons, unless there is, again, a psychological impact of incontinence on sexual activity. Let me give you some examples of what people say. Tell me if these are forms of incontinence. If I say, I feel the urge to pee as soon as I step in the house, but I only have a few drops. I turn on the tap and I feel the urge to pee. If I step outside in the cold, I feel like I need to pee. Are these cases of incontinence? Well, so it depends if there's urine leaking. These are all symptoms that can be related to an overactive bladder. Is this due to the prostate blocking the canal, or is it simply due to something else unrelated to the prostate? These are urge symptoms, as we call them. They're both very classic, turning on the tap and such. The patient feels a strong urge to pee. Why? With an overactive bladder, the brain can send wrong signals. The signals transmitted are not properly controlled. These are circumstances where patients can learn to regulate these symptoms. There are techniques that we can teach them to do so. Treatment options are also available, but there are techniques to manage these urge signals to not fall victim to them. Are there moments where incontinence could be considered a medical emergency? Well, with patients for whom it is impossible to pass urine, or with neurological symptoms, that's extremely urgent, yes. And also, if urinary leakage happens kind of randomly without any precursors, then we may wonder if there's urinary retention. With urinary retention, some patients will pass a little bit of urine or also have some leakage haphazardly without this being associated with an overactive bladder, for instance. So again, we need to ask the question, could there be a blockage? But in terms of emergency, that would be if it's impossible to pass urine or if there's any neurological symptoms. Again, Incontinence onset is not an emergency, but it needs to be looked into. So, to wrap things up for the first part of this webinar, from the moment where we have urinary symptoms that are persisting, men should see a physician regardless of their age. In the case of also a bladder that doesn't empty out over 24 hours, or if you have urinary symptoms coupled with fever, chills, pain, then this would be an emergency and you need to go to the ER. Yes, so we hadn't mentioned urinary infections yet, but yes, fever can be associated to an infection. In these cases, patients should seek medical care quite promptly. For non-urgent incontinence, you can simply discuss this with your physician whenever you see them. Primary care physicians are very well trained in order to do the initial assessment and do a good chunk of the work. You don't need to see a urologist right away. Family care physicians have a lot of experience dealing with that. And we mentioned this a little bit early in the webinar. Having any pain with passing urine related to infection. Does this always come with fever and chills, or can it be pain only? Well, okay, so pain with passing urine is typically linked to an infection, but there could be other causes for pain while passing urine. So again, we need to look into this. If the infection is only linked to the bladder, then there can be a burning sensation without fever. Most of the time, if the infection has progressed and went, say, to the kidneys, then we can have fever. So in this case, if you have fever, you need to seek care urgently. If you have other symptoms like pain, then it's not as urgent. Now, moving on to diagnosis and available treatment for incontinence. What happens if we're sitting at the physician's office, I'm sitting in front of you along with my boyfriend or my spouse? How do we go along diagnosing the cause of what's going on? Well, the key point here is to have a robust questionnaire. Really go through the whole story. Just with these questions, most of the time we can pinpoint the cause of incontinence. There's a lot of clues that we can gather from what the patient can tell us. So in most cases, we can pinpoint again the reason for incontinence. Then there can also be some tests that can be run. Not very invasive. We typically do culture testing with a urine sample just to make sure that there is no infection at play. Oftentimes, we ask the patient to fill out a urine calendar. So the patient measures the volume of urine over 24 or 48 hours. This gives you an idea, and they also log the times of urine leakage. Excuse me? It's like a logbook? Yes, precisely. So the patient uses a measuring cup to measure the output volume and also the times of urination, especially important to diagnose an overactive bladder. And with regards to urinary retention, we can have an ultrasound on the bladder. So patients will urinate in the waiting room, and then we do a quick ultrasound and we can see how much urine is left in the bladder to know if the bladder can empty out. So we eliminate any doubts about urinary retention. Okay, and once we have an idea of the underlying cause, what is the next step? Moving on to treatment, what would be an effective treatment for incontinence? Are there any to start with? What do you recommend? Well, this is quite broad. I would divide this in two categories. First, stress incontinence. This is typically related to prostate cancer surgery. Please note, we're talking about surgery, not surgery for prostate blocking the canal. In these cases, incontinence is quite rare. I'm really talking about surgery for prostate cancer. This is stress incontinence. In this case, we can mainly use exercises with a pelvic or perineal physiotherapist. There can be surgery also. We can back to that later. Now, with relation to urge incontinence, so a pressing desire to pee, the very first step is to change your lifestyle habits. We can influence the outcome and your risk factors a lot this way. If that doesn't work, then we can move on to medication and other more involved treatment. With regards to overflow incontinence and urinary retention, then we typically use a catheter to empty out the bladder, and then we look at other treatments. And this is for urgent or semi-urgent cases when the patient is unable to pass urine. So there's a gradation there. So lifestyle habits first. If that doesn't work, then medication. And if that doesn't work, then we can look at other treatments. Okay, so you mentioned several things. This led to several questions in my mind. Let's start with medication, because this is one of the therapeutic options. I believe this is oral medication. How long does it take before the medication can lead to symptom improvement? Okay, so medication is related to overactive bladder syndrome, so a pressing desire to pee. The medication doesn't act right away. It takes several weeks to act. And there are various doses, of course. So we start with a smaller dose. We see how things work out. We wait out for a few weeks. And if that doesn't work, then we can increase the dosage according to the situation. So we're talking about at least 4 to 6 weeks. The improvement can also be faster, but we shouldn't, take it for 1 week and say, oh, it's not working. Once the medication reaches the bloodstream and we have a kind of a balance reached out, then we need to take the medication at the same time of the day. It can be morning, it could be evening. When we take the medication, the drug doesn't get to your blood straight away, This is really a balance that we're trying to reach. Okay. And you mentioned that before medication, we look at lifestyle habits. Of course, disease is heavily influenced to our lifestyle habits. So are there exercises that can improve symptoms of urinary incontinence? Or what do you suggest as far as lifestyle goes? Well, with relation to exercises, with a physiotherapist for stress incontinence after a prostate cancer surgery, this is done to strengthen the pelvic floor. These exercises can also be beneficial for patients who have overactive bladder syndrome. So when you receive the signals, sometimes the patient can contract pelvic floor muscles, and this sends the signal to the brain to calm things down. That's one option. The most classic case with regards to an overactive bladder is all bladder irritants. So we're talking about coffee, tea, Coke, Pepsi, iced tea, all brown drinks, basically. These are the main culprits. I've seen many patients drinking 8 or 10 cups of coffee a day, have a lot of issues. They reduce their coffee consumption to 1 or 2 cups a day, and the symptoms resolve completely. So yes, there's a strong causal relationship there. Also, patients sometimes develop unhealthy mechanisms. They listen to their bladder a little too much. If you feel the urge to urinate, you shouldn't hold it in, okay? You shouldn't urinate just once or twice a day. That's not good for the bladder. That's one extreme. But some patients urinate 10 or 15 times a day because they're afraid of leakage. So they're emptying out their bladder very often, and then this creates a vicious cycle. We're trying then to train the bladder. If you went just 30 minutes ago, and if your bladder can empty out properly, then try to delay it by 5 or 10 minutes. Not hours, but a few minutes. Try to bring your attention to something else, Try to break this habit and disrupt the rhythm of going right away, because patients tend to go, as soon as I feel something, I go to make sure to avoid leakage. So they become overly sensitive to their urge signals. So we're trying to disrupt this without, of course, holding it in for hours. Yeah, it's the worry of, oh, leakage is going to happen. People try to be proactive, but then they get caught up in something of a vicious circle. Right. Well, if you're going outside of your home and you don't want to have leakage, then that's fine. But we're talking here about people where, their whole lives revolve around this. They're living at the mercy of their bladder. So with these exercises, it may not resolve everything, but that plus lifestyle habits and some medication maybe, can improve the situation. What about Kegel exercises that we recommend to women? Should we see a professional or can we perhaps just Google it? So yes, indeed, they are Kegel exercises. Personally, I'm a strong believer in pelvic or perineal physiotherapy. I've seen patients, they say, yes, I do my Kegel exercises, and they do it in front of me and their face cramps up. So that doesn't do anything. When patients say, yes, I do these exercises, that's one thing. But if they want true impact for their health, really seeing a professional is unequivocally the best solution. It's important to have physiotherapists that are specialized in these issues. They're very well trained, they're excellent. For male patients, you just need to make sure you have an appointment with a physiotherapist that does treat men. Not all pelvic floor physiotherapists treat men. It's a little bit more complex, especially if we're talking about a prostate surgery. So just keep in mind to check with the physiotherapist that they do take up men. Not everyone can perhaps afford it, but if you can, this is really the recommendation. You also talked about surgery. We'll get back to that. But before then, 2 questions. What about natural products? Is this something that is recommended or can it worsen the situation? Well, so there is no natural products that can help or worsen. Well, worsen maybe, but there is no natural product that can help with urinary symptoms or incontinence. I think what's important, though, is to tell your physician if you're taking these or consider doing so, because some have a consequence or on some of the tests we can run. Sometimes patients are scared, to tell us it's okay. If you consider taking them, or if you are taking them, just tell us so that we keep that in mind as part of our follow-up. But in medical literature with studies, there is no benefits to natural products. If some people feel that it's helpful, then great, just tell us. If you consider it, then just check, run it by us. We need to check about drug interaction, for instance. So please just say it if you are taking natural products or consider doing so. Yes, I was asking the question for this reason. Many people wouldn't think that their supplements or raspberry tea or something like that, can have an impact or a negative impact at least. So yes, we need to really run it by the physician. Now, can stress worsen urinary incontinence? You were talking about this vicious cycle, so I assume yes? Yes, especially for urge incontinence and overactive bladder syndrome. So yes, this can have an impact indeed. Oh, actually, yeah, let me add to that. It's not stress that's causing the bladder to contract, but it's the whole dynamic, right? People feel more stressed and they are more anxious to have urine leakage, but stress in and of itself does not generate urinary incontinence. Okay, and I said I had 2 questions, but I have 3. You mentioned coffee. I'm sure you broke the heart of many people tuning in tonight. Are there other foods that we should avoid? Any other things that we should avoid in these cases? Well, so if we look specifically for overactive bladder syndrome, it's tea, coffee. Decaf is a bit better, but water is always best. Make no mistake, water is best. Now, this is a matter of quality of life. If I make sure that nothing is dangerous, that there's no retention, and urinary symptoms are really just related to an overactive bladder, and if the patient doesn't mind using the restroom a little bit more or have some leakage, then it's not dangerous. If you want to improve your quality of life with regards to urine management, then reduce your coffee consumption. But if you're passionate about coffee and this is all you want to do, well then, eliminate the dangerous stuff, but then it's up to the patient to decide how to lead their lives. What about decaf? Better. Not perfect, but better. Okay, I'm trying to think of other foods. Are spicy foods an issue or other types of foods? Well, so not really. Not really with regards to urinary incontinence. When people drink alcohol being a diuretic, we lose the ability to produce concentrated urine. So there are higher volumes of urine, and this can lead to incontinence or influence in that way. Now, foods don't really relate to overactive bladder syndrome. It can be related to other types of issues, painful bladder. Some people are sensitive to some foods that can cause discomfort, but it doesn't relate to incontinence as such. Okay, so we really just need to be mindful of tea, coffee, Pepsi, Coke. Okay. Now, getting back to surgery options, I'm very interested in hearing more about that. I assume that there are several types of surgery in order to treat urinary incontinence. I also assume that there are side effects. So, surgery mostly applies to post-surgery for prostate cancer. Now, as a side note about overactive bladder syndrome that is unresponsive to treatment, so it means we look at lifestyle habits, the patient does everything as they should, medication isn't working, and the situation is serious. We try to widen the duct, that doesn't work either, and there's persisting urge incontinence. Despite all of this, sometimes we can inject Botox in the bladder. As a smaller procedure, this can help to reduce the urge incontinence in some specific cases. Of course, we eliminate any other causes beforehand. Most surgeries, though, apply to stress incontinence following surgery for prostate cancer. What matters the most here is to understand what is the quantity of urine leaked. Each person has their own tolerance threshold. Some say, I'm losing a lot of urine, others say a little, but it is very subjective. So what we do is we have a pad test. Patients weigh their pads and thus measure the volume of urine leaked. This gives us an objective number about the volume of urine that leaked. So depending on the symptoms and on this volume, then we can offer various types of surgery. The second thing to consider, the activity level of the patient. If the patient is young, very active, they like to chop their own wood, working very physically, then they can feel sphincter problems more easily. If someone does office work, then that's a different story. So putting all of this together, the first thing here is to do physiotherapy and give it some time after surgery. Men come to us after 1 or 2 months and incontinence is improving already. So we wait it out. Typically, there's improvement up until 12 months, sometimes even 18 months post-surgery. If despite surgery, despite giving it time, incontinence is still serious enough and bothersome enough to the patient, then there are 2 options. First, for light to moderate incontinence, we can use a strip under the urethra. So this is an outpatient surgery. We open the perineum between the scrotum and the anus. When we use a strip, we put in a strip that acts as a choker for the urethra. In some cases, there can be a balloon with an apparatus to inflate it, to adjust it depending on symptoms. If incontinence is moderate to severe, we can use an artificial sphincter. So this is literally a sphincter that we put in It's a whole apparatus that you can see here. So there's a collar that completely obstructs, completely compresses the pipes, so to speak. When the patient wants to urinate, they press on a pump. It's hidden in the scrotum. And the water goes to a reservoir hidden in the stomach. So the patient takes time to urinate. When they're done, the water goes back into the collar to compress everything once again. Again, this is an outpatient day surgery, and this is done with specialized urologists. Not all urologists do this. Now, with regards to side effects, again, this is plumbing, so we can have breakage. Sometimes also infection can happen, but still, this is well tolerated. The durability of the sphincter is to be considered. It needs maintenance and touch-ups. There can be incontinence later on, and then we need to adjust the sphincter. But still, this is well tolerated. This isn't a light treatment option. This is an implant. It can work very well, but indeed there are sometimes side effects. But it's very well tolerated in most cases, and patients are very happy with it. And are implants used as a last resort? Yes. As I was saying, we need to work at this in a stepwise fashion. First, physiotherapy exercises, give it time, and then if incontinence persists, then we categorize it. It depends also on the patient profile, and then we ask the question, what kind of a treatment do they want? Is it a strip or the artificial sphincter, which is the gold standard, the most effective treatment option? This is what I meant. So a patient can't just say, I don't want to wait it out. I just want surgery right away. Well, again, let's put things in perspective. We don't always wait 12 months. After 6 months, if someone has severe incontinence that really lowers their quality of life, then we can start looking at pad tests and things like that and putting things in place. So it's not a hard line here. But we do see improvement throughout the first year. That's significant. So incontinence should be really severe if we don't wait for the whole 12 months. So that occasionally happens. After radical prostatectomy, incontinence after 1 year is about a 10%. So it's temporary for nearly all men. With physiotherapy, we can accelerate the process to restore continence, but after 1 year, it stands at about 10% of cases. That encompasses both people with just a few drops and some people with more moderate or severe. And these implants are permanent, right? Yes. They could be removed, but the idea is that they're permanent, yes. Can incontinence fully resolve post-treatment? Well, so with a sphincter, yes, patients can be fully continent. With the strip, that can also happen, depending on the incontinence degree to start with. We need to have realistic expectations. Perhaps with the strip, there will be a little bit of leakage or not. With the sphincter, sometimes things are not perfect, but this is the best treatment option that we have under our belt. So sometimes we need to lower expectations. If people say, I don't want to lose a single drop ever again, that may not be completely possible, but still, outcomes are excellent with the sphincter. Okay, and if we don't need to go down the implant route, could one hope to be one day fully continent if they apply the advice about lifestyle habits, exercises, and techniques to avoid the vicious cycle, etc.? Well, again, we need to look at the two types. For urgent continence, definitely this can be well treated. We have medication options, treatment options, and surgery even. So definitely. With regards to incontinence post-cancer surgery, then yes, we can reduce incontinence so that it works within their life parameters. If it doesn't, then we can discuss implants. The idea is no one can be dry 100% of the time. I always tell patients, if you drink several beers and then you go chop wood, you may have a little bit of leakage, but we don't do that every day, do we, right? The idea is post-prostate surgery, we want to have the best quality of life possible. If quality of life is still altered, then we can think about implants. But yes, incontinence can be resolved. This is great news. I have 2 questions left for you. We're talking about resolving or restoring continence. Can it be cured, though? Could we say that? Well, yes, depending on the cause. If the cause was urinary retention, then that can be treated, and with surgery, we can be cured from that. Overactive bladder syndrome can be controlled with medication or lifestyle habits, and then incontinence is fully cured. Or post-prostate surgery, we can have temporary incontinence and things can heal by themselves, which is what happens with most patients. So yes, incontinence can be cured, fully cured. Yes, definitely. So good news all around. Yes, but this requires work between the patient and their physician. So to wrap things up, top 5 pieces of advice for people coming to you with urinary incontinence. Okay, well, first, discuss this with your physician. Don't be embarrassed. People feel that this is taboo. Sometimes they're even ashamed to have that, but it's important to discuss this with your primary care physician if you have any concerns. That's the first thing. Second thing, the patient needs to take responsibility for their health and try to apply advice relating to lifestyle habits, for instance. Sure, it's easy enough to take a pill, but if we can fix, say, coffee consumption, then we may simply not need medication. Then we also need to monitor our symptoms through time. It's great to have urination logbooks. Sometimes patients come to me and say, your medication and your treatment didn't do anything for me, And I say, look at this. 1 year ago in your logbook, you used to pee 10 times a day, 4 times a night. Now you're at 5 times a day and 1 or 2 times per night. And then they go, oh, so monitoring symptoms and maintaining awareness of progress is encouraging, So that's helpful too. Now, with regards to both urge incontinence and stress incontinence, we need to really use physiotherapy to the fullest. Yes, it requires an investment in time and energy. It's easier to ask someone to do something for you, like prescribing a pill or have surgery, but fully investing oneself in physiotherapy leads to extraordinary outcomes. Some patients are highly motivated, and I refer them to physiotherapists before surgery. This way, they can hit the ground running and know how to perform exercises right after surgery, and they can recover more quickly. So then they gain time, they gain recovery time, that is. I think that's 5, right? I think we're good. Last question. You mentioned earlier that we need to make sure that the physiotherapist knows how to handle male patients specifically. We know that people are tuning in from everywhere in the province. There are smaller cities. So could our urologist provide a list of physiotherapists that we can go and see? Yes, definitely. So each region has their physiotherapists. You can use a search engine to find them. Definitely look for pelvic or perineal physiotherapy. So that is one way to find them. It may be more difficult to find in smaller urban centers, but they're pretty much everywhere in Quebec. Again, do ask that they take on male patients. Otherwise, there are primary care physicians who are highly invested that have a list of recommendations. And if you see a urologist, then for sure, they all have recommendations from their patients for physiotherapy. So there are many ways to find them. Unfortunately, the costs are not always covered by the government. We need to have insurance if we want this covered. So we're trying to develop this for expense coverage, but it's not done. Alrighty. So we're reaching the end of our time together. Thank you so much for being with us. I'm drinking water, by the way, and I will tell everyone that water is better than coffee. No, coffee is good. I drink it. Everybody drinks it. Coffee's good. But if it leads to urinary symptoms, then moderation is best. Yes, precisely. Well said. For everyone at home, thank you for attending. We know that you may have questions coming to mind at any time when you're not sitting with your physician, you don't have Dr. Trudeau with you. So please know that Procure is here to support you. You can always have a look at our website or use our support phone line where we have health professionals to support you. Thank you again, Dr. Trudeau. And thank you for attending.
We warmly thank our experts and our partners for making this webinar possible. To find out more about the tools and resources available to you, or to make a donation, visit procure.ca. Thank you for your support.